Everyone, so in this video we will talk about neonatal hypoglycemia, which is a very common condition seen amongst newborns, especially the high risk ones. And in this video we will talk about the definition of hypoglycemia, what are the risk factors, clinical features, investigations, management, and how can we prevent hypoglycemia. According to IEP, different values for symptomatic and asymptomatic hypoglycemia should be used. For symptomatic hypoglycemia, the random blood glucose level less than 40 milligram per deciliter is used as a cutoff, and for asymptomatic hypoglycemia the cutoff depends upon the hours of life. If it is 0 to 4 hours, then the cutoff of less than 25 milligram per deciliter is used. Then if it is between 4 to 24 hours, the cutoff of less than 35 milligram per deciliter is used. If it is between 24 to 48 hours, the cutoff of less than 45 milligram per deciliter is used. And if it is beyond 48 hours, the cutoff of less than 60 milligram per deciliter is used. Now, according to WHO, the random blood glucose level less than 45 milligram per deciliter is said to be hypoglycemia. Moving on to the risk factors of hypoglycemia, it can either be due to the decreased production of glucose, increased utilization of glucose, or decreased mobilization of glucose, or any drugs. So starting with the conditions where there is decreased production of glucose or decreased stores of glucose are seen in preterm babies. It is risk factors for intrauterine growth retardation or small for gestational age babies. It can be seen in babies in whom the breastfeeding is delayed. Conditions where there is increased utilization of glucose are hyperinsulinemic state, perinatal stress conditions like sepsis, shock, respiratory distress, perinatal asphyxia, hypothermia, and post-resuscitation. It is glucose is also utilized more in post procedures like double volume exchange transfusion, and it is also more in polycythemia. The decreased mobilization of glucose is seen in inborn error of metabolism, and it is seen in glycogen storage disease, tyrosinemia, galactosemia, fructose intolerance, and maple syrup urine disease. Moving on to the drugs like maternal intake of beta blockers. Maternal beta blockers reduces the sympathetic stimulation and also interferes with the gluconeogenesis, and it also interferes with the recovery of insulin action. Moving on to the clinical feature of hypoglycemia, it is divided into two parts, that is symptomatic or asymptomatic, and symptomatic is further divided into adrenergic and neuroglycopenic symptoms. Now, starting with the adrenergic symptoms, it include tachycardia, that is increase in the heart rate of the newborn, then tachypnea, that is increase in the respiratory rate of the newborn, and diaphoresis, that is excessive sweating is seen in these newborns. They could be pallor, they could be poor feeding or poor suck reflex, or they could be the temperature instability, etc. Now, moving on to the neuroglycopenic symptoms, it could be in the form of jitteriness, seizure, or apnea, or they could be lethargy, irritability, and any tone abnormalities. So, starting with the investigations in hypoglycemia, you do not need to do routine screening in appropriate for gestational age term babies. In these babies, you should start breastfeeding as soon as possible, and if there is any risk factors present, then you need to do screening at 0 at birth, at second hour, at 6 hour, at 12 hours, at 24 hours, at 48 hours, and at 72 hours of life. Okay, how do we do the screening? Screening is done by using a glucose strip reagent testing or point of care testing, and in this the blood glucose level is 15% less than that of the plasma glucose level. If there is low levels of glucose in this, then you can send the whole blood for testing, but do not wait for the investigations to come to start the treatment. You should initiate treatment immediately without waiting for the reports, because for every 1 hour delay in starting the treatment, there is fall in glucose level of 6 milligram per deciliter, and so you should initiate treatment as soon as possible. Moving on to the management of hypoglycemia. In while managing the patient of hypoglycemia, we take the target glucose level at more than 50 milligram per deciliter, and if the patient is asymptomatic and blood glucose level is less than 40 milligram per deciliter, we will consider the oral feeds first, and then again check the values at 1 hour, and still if there is hypo, then we will consider IV dextrose infusion at the rate of 6 milligram per kg per minute. And if the patient is asymptomatic and blood glucose level is less than 35 milligram per deciliter, then we will directly consider IV dextrose infusion. And on the other hand, if the patient is symptomatic and blood glucose level is less than 40 milligram per deciliter, we will directly initiate the IV dextrose infusion, and do not wait for anything else. And if the patient is symptomatic and blood glucose level is less than 25 milligram per deciliter, we will first give the IV dextrose bolus, 10% dextrose dextrose bolus at the rate of 1 to 2 ml per kg IV dextrose bolus. Then following which we will start the dextrose infusion at the rate of again 6 milligram per kg per minute. We check the values in every 30 minutes. How can we prevent neonatal hypoglycemia? Neonatal hypoglycemia can be prevented by giving exclusive breastfeeding as soon as possible, preferably within 1 hour after birth. Frequent feeds should be given on demands, and skin to skin contact should be done. Example, kangaroo mother care should be done in low birth weight stable neonates. There is no role of water or glucose water under any circumstances.